Okay, good morning everyone. We'll do a quick ICU quiz for Saturday morning. Um, First question is, if you have a baby who presents to your ICU with heart failure, and you look at the echo and there's nothing, there's no structural lesion, there's no VSD, there's no PDA, there's no AP window, what conditions present with heart failure but don't have a fixable structural lesion? There's no coax, there's no CAPVC, there's nothing. So what are the lesions that present with heart failure without a structural lesion? Can you name a few? Okay, good. So anemia, thyrotoxicosis, arrhythmias, AV fistulae. Yes. And then of course your myocarditis and dilated cardiomyopathy. So if you have a heart rate greater than 220, then you consider, is this STP that's presenting, is this tachycardia induced cardiomyopathy? Of course, myocarditis and dilated cardiomyopathy. And yes, you should consider things like beriberi, very uncommon in today's day and age, but can be considered thyrotoxicosis, and also listening for bruise. So listen, put your stethoscope on the anterior continent, consider a vein of Galen aneurysm, and actually pulmonary AVMs don't present with heart failure, they present more with cyanosis, but hepatic AVMs. So again, put your stethoscope on the liver and listen for any bruise. So think of extra cardiac causes as well when you have heart failure. Okay, now things not to miss. If you have a 1-month-old who's crying with fever, pallor, he's got heart failure, on exam he's got signs of heart failure, low output murmur, holosystolic murmur, X-ray says cardiomyopathy, and he's been reported as dilated cardiomyopathy on echo. So if you have someone who your diagnosis is dilated cardiomyopathy, what are the structural things you shouldn't miss? What are the 3 or 4 things that you should make sure you exclude? Yes, coarctation is one of them, Alcapa is one of them, and critical aortic stenosis. You need to make sure you're looking at your coronaries very well, you're looking at your arch very well, and look at the aortic valve. Even if you don't get a gradient across the aortic valve, if the jet is very narrow and you don't have a much antegrade flow, think of critical aortic stenosis. And of course, coarctation. Again, tachycardia-induced myopathy. So an ECG is always helpful in these kind of patients. Okay, 3-day-old with shock. Listless, lethargic, poor perfusion, all pulses weak. What lesions do you think of? 3-day-old with shock. All pulses are weak. So, if it's all pulses weak, right, all pulses meaning carotids, radials, femorals, then you would think of HLHL or what is the other lesion? So you won't be thinking of a coax if all your pulses are weak. So if all pulses are weak, when I say all, that means femorals, radials, carotids, right? Then you're thinking of something from the LV is not coming out. So it can either be a hypoplastic left heart or, so again, interrupted aortic arch. Once the PDA closes, your femoral pulses will be weak, right? You won't generally have, you'll have good carotids, or you may have a good radial. You won't have a kind of all over your pulses are weak. Yes, so if you have cardiogenic shock, all pulses will be weak, right? And which cardiac lesions all pulses will be weak? Yes, critical AS and hypoplastic left heart. So whenever you think, when all pulses are weak, and that's the importance of, if you have a kid with poor perfusion, you feel the femoral pulses and then feel his radials and feel the carotids. If all of them are weak, then it is something from the cardiogenic, whether it's cardiogenic shock or it's a hypoplastic left heart or it's a critical aortic stenosis. On the other hand, if only femorals are weak, then what do you think of? Then you're thinking of coarctation or interrupted aortic arch, something that is only going to affect the lower body perfusion. All clear on that? And that is the importance really in kids where you don't have a pulse, to not just feel the femoral pulse, but to make sure that you also feel the carotid. Sometimes the radial you can feel, but just make sure you feel the carotid. If the carotids are also weak, this tells you that this is a cardiac. It's coming from some problem, some critical problem with the left heart, whether cardiogenic shock or left heart obstruction. Okay, all clear on this? Now, a couple of scenarios in your ICU. If you have a baby who has low blood pressure and high CVP, what do you think of? And so it's very important whenever you have a baby with low BP, you also quickly look at the CVP line. So if you have low BP and high CVP, okay, good, post-op pulmonary hypertensive crisis is one. What else? Low BP, high CVP. Anything else? What is your differential diagnosis? When you see low BP, high CVP. So RV failure, okay. PA crisis, okay. RV failure. AV valve, obstructive shock, ventricular dysfunction, okay. I mean, if you can, generally to get a left heart obstruction or left heart dysfunction, and then, by the time it goes back pressure, you can get your CVP, fair enough. Anything else? So PA crisis for sure. One more thing you must think of. When you have low blood pressure, high CVP, what compresses the heart? Yes, so you must immediately think of pericardial effusion. In fact, pericardial effusion is the first thing. If you ask me, blood pressure has fallen, CVP has gone up, I would think of pulmonary crisis or pericardial effusion. So very important immediately to quickly do an echo and differentiate these two. So pericardial effusion, right heart failures, pulmonary hypertension. Okay, so please remember tamponade or pericardial effusion. The minute BP drops, CVP will go up like 15, 20, 22. You quickly do an echo. This will differentiate. If there's fluid around, it's pericardial effusion. If RV is dilated, severe TR, this is right heart failure. If PA pressure is high, the TR jet will be high. So you can easily differentiate these because the management is different. If it's a pericardial effusion tamponade, what are you going to do? What's your management? You're going to? What will you do if it's a tamponade? Yeah, you're going to immediately put 2 pericardiocentesis. If it's pulmonary hypertensive crisis, what are you going to do? What are you going to do if it's a pulmonary hypertensive crisis? So you're going to, well, if it's a pulmonary hypertensive crisis where the BP drops, CVP goes up, you need to immediately do bag and mask. The first thing you will do is ventilate them, bag and mask, because by the time you get your nitric oxide, pulmonary vasodilators and so on. So immediately you need to do bag and mask, give them oxygen, give them bicarb if needed, and then of course add your pulmonary vasodilators in. Okay, but oxygen is a very potent pulmonary vasodilation, and bag and mask is a very good way to come out of a pulmonary hypertensive crisis. So the minute you have BP drops, CVP goes up, it's not a tamponade, they're thinking pulmonary hypertension, just bag and mask them with oxygen, and that should help the pulmonary vascular resistance drop again. Okay? Next one, low BP, low CVP. What do you think of? So the blood pressure is low, CVP is also low. So you think of a low cardiac output state, okay, like what? When we say low cardiac output, we mean that, what do we mean when we say low cardiac output? We just mean that the cardiac output is low. Now let us say there was low BP but high CVP. That is also a low cardiac output state, right? But there the differential diagnosis is effusion, pulmonary hypertension. So more specifically, yes, hypovolemia. When you see low BP, low CVP, you think of hypovolemia. You think this baby is needing fluid. The other thing you can think of is LV dysfunction. Now it is true when you have LV dysfunction long term, you can get back pressure, PA pressure, RV failure, and CVP going up, but that's a very long process. Generally with LV dysfunction, if everything drops, you get your low BP, low CVP. So you can quickly differentiate these two. How? How will you differentiate hypovolemia versus LV dysfunction? So response to volume, yes, but generally in your cardiac ICUs, you have an echo machine. Quickly do an echo. In LV dysfunction, LV will be dilated, it won't be contracting. In hypovolemia, how will the ventricles look? In hypovolemia, what kind of ventricles do you get? Hypercontractile and collapse. You get they look like there's nothing in them, right? And so you can very quickly in a 1 second echo, hypercontractile collapsed ventricles versus dilated dysfunction ventricles, you can make your diagnosis, which is then accordingly you're going to treat them. Other things like hypocalcemia, which can again affect your myocardial contractility, and of course again arrhythmias. So every time you have low BP, look at the CVP, look at the rhythm strip. If the BP is low and there's an arrhythmia, then that itself will cause it. Hypothyroidism, yes, though generally will be acute in your ICU. Okay, high BP, high heart rate in your ICU. Patient post-op, high BP, high heart rate. What do you think of? High BP, high heart rate. Inadequate sedation or analgesia, excessive inotrope. Arrhythmias you won't think of because generally arrhythmia is not going to raise your blood pressure, right? It may raise your heart rate, but along with the heart rate going up, the BP is going to come down. So it would be unlikely to be an arrhythmia. So you can think of a excess inotrope, deficient sedation, or patient who's paralyzed and not sedated enough. But pain is the first thing you must think of. High BP, high heart rate, look at the pain meds. Have I given this baby enough analgesia? Okay, after pain, inadequate paralysis and sedation. Okay, high BP, low heart rate, what do you think of? High BP, low heart rate. Yes, refer immediately. If it's a 6-month-old with high BP, low heart rate, what will you do? You think he's got increased intracranial tension, you're worried about a bleed, what will you do? High BP, low heart rate. You will immediately check his anterior fontanelle. And you can, in fact, all you PD cardiology guys must learn a little bit about cranial ultrasound. So in all the kids in whom the fontanelle is not closed, when the BP goes up, heart rate comes down, you think of a bleed, you can check the fontanelle, is it bulging, you can put your probe and look for a bleed in the brain. Of course, you will call your radiologist and so on. And then you're going to hyperventilate and treat that bleed. Mannitol, so on, depending on your management. Okay, so my advice to all of you is do a little bit of time with your radiologist and learn cranial ultrasound as well. So which inotrope to use when you have heart failure with a stable blood pressure? What are your inotrope choices? Baby is in heart failure, but BP is okay in the sense that he's tachypnic, he's got retraction, liver's down. So, but his blood pressure is okay. So, dobutamine, milrinone, dopamine. So, BP is stable. If BP is stable, and you can consider using more vasodilators or afterload reducers, right? Because they will increase your stroke volume, improve your LV compliance. So, what are a few vasodilators? Milrinone is one, that's right. Dopamine, lower dose, right? So, vasodilators. Any other vasodilators you could use? Heart failure, stable blood pressure. So, you can use things like FMC, right? So, generally, if your blood pressure is stable, and you've got heart failure, you may want to avoid too much of dopamine because again that's a vasoconstrictor. The issue is not so much BP. So there you're going to use more of vasodilation. Yes, you could do that if your ICU is using it. That is fine too. So Milrinone, what is the action? How does it act? And what are the side effects? Action of Milrinone. So it's in, how does it act? Yes, it's a phosphodiesterase 3 inhibitor, right? Inodilator. Side effects of Milrinone? Side effects? Thrombocytopenia, hypotension, hepatic dysfunction. Does anyone say that? No. So, it's a phosphodiesterase 3 inhibitor. It has positive inotropic effects as well as vasodilation. That's why it's called an inodilator. And it also helps improve diastolic function. Also helps with this pulmonary hypertension. It's a good pulmonary vasodilator. Side effects, thrombocytopenia was more with Milrinone, but okay, long-term usage. We don't use it typically for more than 72 hours. It can cause hypotension. Please remember, it can cause ventricular arrhythmias and hepatic dysfunction as well. And so, you need to know its side effects when you put a patient on it. And typically, you don't want to use it for more than about 72 hours. Okay? Now, what about nitroprusside, SNP? Mechanism of action, side effects. Side effects. So, okay, so it is, and it's a nitro vasodilator, right? So, it's a nitric oxide mediated vasodilation, acts on the arterial and venous pathway, and therefore it's very good when you have high LV filling, like you have diastolic issues and as well as increased systemic vascular resistance, right? So if you have high SVR with high LV filling pressures, it's a good drug. It has a rapid onset of the action and it does cause hypotension. So again, the advantage is if it causes hypotension, you can quickly switch it off. It's mostly an arteriolar dilator. You have a broad range in its dosage, but just start at the lower dose and then you can ramp up. Because the good thing is you can suddenly stop it. The bad thing is it can cause hypotension. Again, you don't want to use it for long term because of long term side effects. Which inotrope to use in heart failure with low BP? Heart failure, low blood pressure. Which inotrope? Yeah, now here you could talk about your dopamine, right? You could add adrenaline. Some people use adrenaline, that's fine. I personally don't like adrenaline because it increases your myocardial oxygen consumption, but our unit uses it, so it's fine, and it's also cheap. It's inexpensive. It's a good inotrope. So you can use something which has vasoconstriction. So dopamine is a good one because it has your peripheral vasoconstriction, and dobutamine is good because it has your improved cardiac contractility. So you can use a dopamine-dobutamine combination so that you get peripheral vasoconstriction and you get improved cardiac contractility. Okay? Now let us say you have cardiopulmonary bypass related what is called vasodilatory shock, where because of all these leukotrienes that have been released and inflammatory mediators, the patient is fully vasodilated and he's in shock, right? And he have low BP, but he's all vasodilated. So you try noradrenaline, adrenaline, yes, these are good drugs. And let us say it doesn't respond. Yes, the drug of choice is, if it does not respond to all your catecholamine vasopressors like adrenaline, noradrenaline, dopamine, the drug of choice is vasopressin. Important to know this because you may keep giving them, pumping with your adrenaline, noradrenaline, but he's still hypoperfused, he's got lactic acidosis, he's hypotensive and he's not responding. Please remember vasopressin is actually your drug of choice It's a very, very potent vasoconstrictor, and it is used in vasodilating shock. Okay, all clear on this? True or false question. Neonate is more likely than an older child to maintain blood pressure in impending shock. True or false? Any other answers? Two? Two false, one true. Anything else? Any other answers? No one wants false, one true, two. Okay. So actually both of these are true. The neonate is more likely than an older child to maintain BP in impending shock, and that is why it's important that you don't use blood pressure as a criteria for your shock. You use by the time BP goes, that poor little baby is gone. So you've got to use more your urine output going down, your hypothermia. You use other indicators for impending shock. Is the temperature dropping? Is the urine output dropping? Is the capillary refill not great? Is he getting a little acidotic? All these things before just looking at the blood pressure numbers. And a neonate is more labile for sure, but also more resilient. And this is related really to, the whole neonatal structure is very different than an adult structure. But they're very sensitive, for instance, to calcium depletion. But then they respond very well if you treat it. They will, they respond well to treatment, and they're quite labile, but also very resilient, unlike adults. So important to keep a close eye on them and not wait for dropping blood pressure. Okay, post-op VSD closure. We'll move on to a few lesion scenarios. Post-op VSD closure, what are the causes of low cardiac output? Patient had his VSD closure, he comes to the ICU, he's got low cardiac output. Names and causes, what do you think of, what do you do? So could be PA crisis, okay. Could be pulmonary artery crisis. What else? Could be ventricular dysfunction. Could be arrhythmia. Could be hypovolemia. Generally, a large residual VSD won't cause low cardiac output. The reason is that the baby was used to a VSD pre-op, right? Because that's what they had. So now even if you leave a VSD, there's really no change in his dynamics. So he's not going to go into low cardiac output from that VSD. This is not true if it's a tech, like a pathology of fellow, you leave a VSD, you can go into heart failure and so on. But in a post-op VSD, generally they are used to high flow. So the things that will cause low cardiac output would be really your myocardial issues, your PA crisis issues, your rhythm issues, and your, what else? The same thing I told you in the beginning, the thing that causes low BP, high CVP. Hypoglycemia could, yes. Low BP, high CVP, tamponade, effusion. Right, so these are all the things to think of. Is it a myocardial stun, which is post-bypass related? Is it LV dysfunction, which could be bypass related? Maybe there was inadequate myocardial protection. Maybe there was an LV distension injury. Maybe the baby's come out with hypocalcemia. Whatever the cause of the LV dysfunction may be. Persistent pulmonary hypertensive issues and pericardial effusions, and I should add in there arrhythmias. Now, how do you differentiate PAH issues, right? Is this pulmonary hypertension versus LV dysfunction? Even before you do an echo, baby comes out, is in low cardiac output. Your echo machine is in the ICU, in the OR. You have to get the echo machine. You don't know if it's LV dysfunction or PAH. Okay, so CVP will be increased in PAH. Yes. CVP will be increased in PAH and may not be increased in LV dysfunction. Anything else, any other lines can help you that the surgeons will leave? They typically leave a left atrial line. So what will happen to the left atrial line in PAH versus LV dysfunction? The LA line, what is the finding in LV dysfunction? So you get high LA pressures in LV dysfunction, right? And you get low LA pressures in PAH. And certainly then you can also, if you have a PA line, which hopefully your surgeon will do, you can look at the PA pressure. If the PA pressure is high, then you will have, that is, pulmonary hypertensive issue. PA pressure may be elevated with LV dysfunction, but generally doesn't go up as much as it goes up in pulmonary hypertensive crisis. And then of course you can do your echo and look for PAH on your CR gradient versus LV dysfunction. Okay? But if you have an LA pressure, LA line, so it's very important when they come out of the OR to check what are the lines available. What can I be looking at to assess this baby? Okay, CVP is there. Okay, LA line is there. Do I have a PA line? And look at all these three in totality. If LA line goes up, right, and CVP goes up, what do you think of? So if LA line goes up and CVP goes up suddenly, what do you think of? You think of tamponade. You think that there's something compressing it, right? So if LA, suddenly your LA shoots up, CVP shoots up, he's bleeding around the heart. If LA pressure goes up, CVP pressure is normal, what do you think of? Sudden rise in LA pressure, CVP is normal. You think of LV dysfunction. Or you think of, yes, you think of LV dysfunction. If LA pressure is normal, CVP suddenly goes up, what do you think of? You think of PA. So a PA crisis. So if LA line is normal, CVP goes up, you're thinking PA crisis. LA line goes up, CVP goes up, you think fluid. LA line goes up, CVP stays the same, you think of LV dysfunction. So just looking at your CVP and your LA line can give you a lot of information about what is going on even before you get your echo machine there. Now to answer someone put a question about issues with the LA line. Well, issues with the LA line are, it can get blocked, it can be positioned where it's against the wall. So then, you're not getting it's a dampened space. Rarely when you pull it out, you can have bleeding. But generally, if you put it in, it's a small little line. The minute you pull it out, the opening tends to close. So if you do it well, in general, you shouldn't hopefully have problems with it. Okay. Now, what increases CVR in the ICU? What are the things that increase your pulmonary vascular resistance? So we said that when you have a patient who has a VSD closure and he comes out and he has low cardiac output, you think of PA crisis, right? So yes, so what are the things that can increase CVR? Could be hypoxia, could be pain, okay, could be suctioning, unsedated suctioning, right? Nurse has gone, so unsedated suctioning, pain, not enough oxygen, hypoxia, anything else? The patient became acidotic. What else? Other things? So bypass related, okay, if you've got all your kind of inflammatory mediators, and then lung issues. So apart from your suction stimulation, if you've got fluid in the lungs, you've got pleural effusions, you've got atelectasis, and if you're hypoventilating the baby, and of course your bypass related things. So these are all the things that will increase CVR in the ICU, right? So what is the best way? If you look at all these things that increase CVR, so obviously you try to do sedated suction, you try to minimize your stimulation, you try to bag them and or basically prevent hypoventilation. If you ventilate adequately, you won't have issues of atelectasis, you won't have issues of hypoventilation. And bypass related things, what can you do to prevent some of this bypass related? What is one of the things that is done to prevent bypass related complications? You can mask them. And you can give them steroids, right? Generally they're given steroids in the OR to prevent this before they even come out. So what is the best way to reduce CVR? Now this baby comes out, is getting PA crisis. So what is the best way you can think of to reduce pulmonary vascular resistance? hyperoxygenate, ventilate. So oxygen is a very potent vasodilator. So even before you're thinking sildenafil, nitric oxide, blue and blah, give oxygen. 100% oxygen is a very good way to drop your pulmonary vascular resistance. So when you think of PA crisis, first thing, bag and mask with 100% oxygen. So that will give you adequate ventilation, and oxygen is an extremely potent vasodilator. Please remember this. Before you answer NO, sildenafil, blah, Milrinone, all that, forget it. Cheap and best is oxygen. Oxygen, you do bag and mask, you sedate, you need to paralyze, you give oxygen, you correct acidosis, you correct polycythemia, and all these things many times will drop your pulmonary resistance. You don't always, of course, if they don't respond to all that, then you're thinking of nitric oxide and medications to reduce it. But before all that, think of bag and mask, oxygen as number one, sedation and paralysis as number two, minimizing your stimulation overall, correcting your acidosis, because pH, an acidotic patient, acidosis also increases PVR, and therefore correcting acidosis is very important. And all the combination of all this should hopefully drop your PVR. Okay, next one. Which of these has the highest incidence of complications? LA line, RA line, CA line. Even I thought that, and you can double check this, but the literature said the PA line had the highest rate. So we have three different answers here, LA, PA, RA. Why don't you guys all read this up? As far as my understanding in terms of when you look at complication rate, it's actually higher with the PA line because it doesn't have that same, contractility that the atrium and ventricles have, because they have a little bit of a better wall, you can say, that immediately closes in, and therefore the PA line is more prone for complications in system. Okay, post-op tetralogy, failure and heart. Post-op cough, repair and heart failure. What are the causes? So patient has post-op cough and now he has heart failure. So first thing you think of, yes, residual VSD. Then you think of RV dysfunction. Could be MAPTA not closed, but generally that is quite unusual, and I'll tell you why. Because if you had a MAPTA, right, if you had a collateral, that was, yes, arrhythmia is the third reason. Now if you had a MAPTA that did not give you heart failure before surgery, right, why should it give you heart failure after surgery? Right, and this issue comes up very often in the ICU, where you've taken a tetralogy of fellow patient to the OR, right? Now the guy was blue, he didn't have heart failure. Now he comes off, his tetralogy of fellow is repaired, and we are saying he got heart failure from his MAPTA. So I will tell you, in my experience of now 18 years in the ICU, that is very, very unusual. So what you can do, you document beforehand if there's collaterals or not, right? If you had a very large collateral, you would have embolized it before. If you didn't have it, there were these small collaterals. It's quite almost unusual. I've never seen one that then causes heart failure after his tetralogy is fixed. So I know many times we go on a little chase for this. So if you're going to the cath lab to look for a residual VSD, you want to do a quick aortogram to make sure you didn't miss, fair enough. But it's quite unusual. More common would be that it could possibly cause you some hemoptysis, because that MAPTA now with the bypass related, the heparin, it bleeds through that. That is a more common presentation of a MAPTA post-op event. So commonly, once you have heart failure after tetralogy of fellow, first thing you got to think of is residual VSD, and second thing would be ventricular function issues, whether they are ventricular function issues from arrhythmia, from bypass related, from the RV not tolerating his pulmonary regurgitation, whatever may be, that ventricular dysfunction can cause heart failure. Now if the tap is not adequate, okay, now to answer that question, in a tetralogy of fellow, if you have you have PF and you have your VSD, once you close your VSD, right? It is true that you must relieve the pulmonary stenosis. Because if you don't adequately remove the pulmonary stenosis, now the blood cannot go to lungs. Now you close the VSD, it cannot go right to left. So you will get RV dysfunction, right? So yes, if you leave behind a lot of pulmonary stenosis, you will have RV dysfunction. That is quite unusual, but yes, you should look for, some poor surgeon who didn't do a stap and has left a gradient of 90 and VSD is now closed. This patient, when you look on echo, if that gradient, if that RVOTO is his cause for his heart failure and his low cardiac output, then he would have a thick, dilated, non-contractile right ventricle, right? So residual VSD would be the most common. Now, how would you differentiate whether this is a residual VSD? You look on an echo, right? And you do a transthoracic echo, and you don't see the shunt. What will you do next? You're thinking, man, this has to be a residual VSD because he's now in heart failure. Okay, you lower the scales, you look up and down, you're not finding it. Will you do a CAT? So will you do anything else? Anything else you can do? If LA line gives flush through it, you could, as a contrast echo in the LA, I personally would avoid that. Reason is because you've got agitated saline, and that if you have any bubbles and by chance it goes out to the brain, so I would personally avoid doing that. I think there are more safer ways to look for a VSD. RAPA step up, yes, that's if you go to the cath lab, or if you happen to have a CVP line and a PA line, you can definitely do an RA to PA step up. And yes, TEE. Okay, every Wednesday in CAT conference I ask the fellows, what else could you have done? What else could you have done apart from a CAT? And the answer is TEE, and I want you all to keep this in mind. If you do not see a residual VSD on transthoracic echo, the next step is ideally a transesophageal echo. Now many times, okay, it's a small baby, we don't have the TE probe, we're not able to do the TE, fair enough. But if we can do the TEE, then that is something to consider before taking up for a cardiac CAT. If you're thinking this could be a collateral that's causing a bleed, there are other things, then a CAT is fine because you can do an LV gram, aortogram, you get all your information. So yes, some of the things to think of are if you have CVP line and PA line, look at it for a step up in the stat. If you can do a TEE, do the TEE. If you still are not sure that this baby is in heart failure, by all means go ahead and do a cardiac catheterization. Okay, I have a whole bunch of other questions, but I am thinking I should stop because I know it's 9:40 and you all have class. So I will stop and then maybe we can continue this as a bonus class another day.